Hello everyone, my name is Trista Anderson and my research proposal presentation is about healthcare professionals offering support to family caregivers. This is the table of contents for my presentation. Quality of life when caring for a chronically ill family member ranging from children to older adults can take a serious toll on family caregivers. Family caregivers are likely not trained in caring for the chronically ill or in symptom management. It is something they must learn as they go, which can become rather stressful. As chronic illness progresses, so does the demand of caregivers, some of which must be with their ill family member at the end of their life. According to Marsak Topowski, caregiving has been associated with adverse emotional, physical, and financial outcomes and can pose long-term negative effects on the caregiver's health. Limited research exists regarding what healthcare professionals such as doctors and nurses can do to offer support to improve quality of life for these caregivers. The purpose of this study is to determine if healthcare providers, including doctors and nurses offering verbal support to caregivers who care for their chronically ill family members, increase caregiver quality of life. Offering support to family caregivers is important to ensure that their needs are adequately being met so they can continue giving the best care to their ill family members. Caregivers can feel a sense of pressure while fulfilling caregiving responsibilities, especially in the case of children with medical complexity because they often depend on technology and their primary caregivers for survival. Support is most likely offered to family caregivers at the beginning of a family member's diagnosis. However, does this support continue throughout their journey? At the beginning of a diagnosis, family caregivers receive support by the introduction of information, emotional support, and other resources to assist in their new normal. After initial diagnosis, caregivers may feel forgot about as the focus must always be on the ill individuals during follow-up healthcare visits. However, this would be a great time for healthcare professionals to assess how caregivers are doing with the diagnosis as well. According to a study conducted by Samuel et al. That aimed to understand factors that can improve quality of life of older caregivers of people with intellectual and developmental disabilities, found that change in caregiver quality of life was significantly correlated with the change in depression, stress, global family quality of life, and employment status. Samuel et al. Also acknowledges that additional research should be done to determine how professionals can alleviate stress and depression symptoms that are specifically associated with caregiving responsibilities. A study by Roper et al. Aimed to assess the mental health, family burden, and quality of life in parents of children with persistent congenital hyperinsulinism. The study is a quantitative cross-sectional study that utilized several instruments ranging from a generalized anxiety disorder scale, patient health questionnaire, quality of life inventory, and a family burden questionnaire. Results showed that low social support was associated with higher family burden, poor mental health, and a decrease in quality of life. Results also showed symptoms of anxiety and depression are highly prevalent among parents of children with congenital hyperinsulinism. A few limitations addressed were small sample size and a homogeneous group with socioeconomic status. A study by Farrell et al. Aimed to develop and conduct feasibility testing of an educational intervention to support family caregivers and symptom management. The study is a pilot project of a quasi-experimental design that utilized two instruments, including a demographic data instrument and the quality of life subscale of the City of Hope Family Caregiver Tool. Results showed that caregivers were interested in their role in symptom management of constipation, dyspnea, and diarrhea. Intervention was shown to be valuable and feasible in assisting family caregivers in assessing symptoms and making decisions regarding treatment choices. A few limitations addressed were small sample size and lack of telehealth follow-up for education reinforcement. A study by Samuel et al. Aimed to identify factors influencing the quality of life of older caregivers of adults with IDD who participated in a peer-mediated statewide family support project called MeOcean. The study is a one-group pre- and post-test quasi-experimental design that utilized several instruments, including a BRED quality of life scale, PSS, which assesses degree of stress, PHQ-9, which is used to assess depression, and ZBI scale, which is used to assess caregiver depression, and also the Global Family Quality of Life scale. Participants who participated in the Meet Ocean reported a decrease in burden, stress, and depression, and an increase in quality of life and global family quality of life. The comparison of pre- and post-test scores were significant. It appears that benefits were seen by completion of the Meet Ocean. Some limitations addressed were a lack of a control group in a population that may not represent the larger population. A study by Marcek Topolsky aimed to determine if the domains of caregiver burden and informal social support were predictors of quality of life for aging parental caregivers of adult children with autism spectrum disorder. The study is a non-experimental, quantitative, correlational research design that utilized several instruments, including a demographic survey, a psychological domain to assess caregiver burden, and another instrument to assess social support. Age and self was reported caregiver health explained a statistically significant amount of variance in quality of life. Developmental and emotional burdens were significant predictors of quality of life in a negative direction. Social support was shown to have a positive impact on a caregiver's quality of life. And some limitations that were addressed were a lack of diversity in caregiver participants and a lack of continuum indicating the extent of the care recipient's involvement. And the last one I'll talk about is a study by Preto et al., which aimed to examine the relationship between caregiver burden, caregiving satisfaction, and health-related quality of life. The study is a cross-sectional study that utilized the Zarit Burden Interview to assess caregiver burden, a caregiver satisfaction scale, and a health survey to assess health-related quality of life. Study shows a negative association between caregiver burden and caregiving satisfaction. Caregivers' education and family income were associated positively with caregiver burden. Data also showed caregivers' education and race were associated with caregiving satisfaction. Some limitations addressed were small sample size and exclusion of Spanish-speaking caretakers. The theoretical framework that underlies this study is the theory of chronic sorrow. The essence of chronic sorrow is the conflict between current reality and desired reality that is a discrepancy from personal, developmental, and social normalcies. The theory of chronic sorrow was developed to assist in the analysis of individuals' responses of those who are directly affected by chronic illness, including but not limited to caregiving responsibilities, the loss of the perfect child, or bereavement. These feelings can be seen as a normal response to the ongoing disparity that comes along with the experience of loss. However, if ineffective coping is utilized, chronic sorrow can develop into a pathological state, such as depression. Although the theory of chronic sorrow is especially relevant to see the relationship between the effects of chronic sorrow on caregivers of a child with a physical or mental disability, the theory can be related to caregiving situations across the lifespan. Caregivers may not always feel saddened, especially after coming to terms with their family member's illness. However, new events such as watching other children hit developmental milestones can feel debilitating and be triggers for sadness. This can be true for older caregivers who must watch their family members require more assistance with completing everyday tasks and lose skills they once had because of chronic illness. The theory of chronic sorrow needs to be studied and understood by healthcare professionals to aid in the understanding of what caregivers caring for their ill family members face and how they can be best supported. Through reviewing current literature, I was able to develop a research question. The research question is, does utilization of follow-up visits that include the offering of verbal support from healthcare professionals such as doctors and/or nurses to caregivers caring for their chronically ill family members increase quality of life as measured by the Family Caregiver Quality of Life tool? The study will be conducted at 2 different institutions to cover caregivers across the lifespan ranging from infants to older adults. Participants will be recruited from the University of Kansas Health System Kidney Institute and Children's Mercy Hospital Adele Hall Campus Kidney Center. From the beginning of the study to the end of the study, participants will ideally visit the clinic on 5 separate occasions with their chronically ill family member where they will receive verbal support from a doctor or nurse. This study can be considered a mixed methods design because I will be assessing both qualitative and quantitative data through themes emerged and through the quality of life tool. Data that will be collected and analyzed for the study will assist in making predictions on how quality of life changes for family caregivers after being offered verbal support by healthcare professionals such as doctors or nurses at 5 follow-up appointments with their chronically ill family member. The instrument I am utilizing will be discussed by participants before and after intervention, which I will discuss further in the next slide. The Family Caregiver Quality of Life tool was originally developed to assess caregiver quality of life in heart failure patients and how caregiving responsibilities have effect on physical, psychological, social, and spiritual domains. The Family Caregiver Quality of Life tool is composed of 16 items that can be administered in a brief and easy to understand way to measure quality of life of caregivers. The survey offers 16 statements that can be numbered 1 through 5, with 1 being strongly disagree, 2 being disagree, 3 being neither agree nor disagree, 4 being agree, and 5 being strongly agree. Statements range from, as a caregiver, I am overwhelmed. Because of caregiving, I am tired. Even though I am a caregiver, I am able to participate in enjoyable activities, and caregiving means meaning to my life. The tool will be utilized pre-intervention and post-intervention to assess for any change in scores that would indicate a positive change in quality of life of participants. I wanted to create a resource for doctors and nurses who will provide this support to caregivers. I have listed some examples of questions that doctors and nurses can utilize to initiate supportive conversations with caregivers. I also want to stress to doctors and nurses to ensure to follow up regarding previous conversations as well. So during these appointments, a doctor or nurse will take the time to offer support to family caregivers, in privacy if preferred by participants. Support can include, but is not limited to, resources for caregivers, offering of home healthcare services, validating emotions, and ensuring the prioritization of their well-being. It is difficult to give healthcare providers strict guidelines for support offerings because different conversations will obviously lead to different support offerings. However, I do want to request that each of these questions above are at least asked once throughout the duration of the study. An estimation of 40 subjects will participate in this study, ideally 20 subjects who are family caregivers of an individual under 18 years of age and 20 subjects who are family caregivers of individuals over 18 years of age. Potential subjects include family caregivers who are seen at the University of Kansas Health System and Children's Mercy Adele Hall campus kidney clinics. Each clinic will receive an informative paper discussing the study that will be given to each caregiver during check-in for appointments to assist in recruitment. This paper will include the lead investigator's contact information in which potential participants can express interest in participation. The benefits that the subjects will have is the opportunity to contribute to the study that aims to address how healthcare providers can offer support to family caregivers. This will help family caregivers to be better supported for future situations. They will also receive a meal voucher for the cafeteria at each institution, as we know that being at appointments can make for long days. The privacy of the subjects will be ensured throughout the duration of the study by offering them a private location where they can disclose their personal feelings in relation to their caregiving duties. Family Caregiver Quality of Life tool can be completed in the privacy of their own home via an online option or in a private setting at the clinic on paper. If completion of the tool or any other study-specific information is documented on paper, it will be stored in a locked file cabinet that only can be accessible by a specified person at each clinic and the lead investigator. Documents will be kept locked in the cabinet until able to be picked up by the lead investigator. Each participant will be asked about preference on location, as some may not require a private location. However, each participant will be given the option and told where the tool can be completed privately within each clinic. Attitudes that may affect participants in this study may include those in the community that have distrust in the healthcare system. Bad experiences from peers or historical biases may contribute to participants' distrust in the healthcare system as well. Participants may get persuaded by these individuals to not trust doctors or nurses with personal information, such as how they are coping with caregiving responsibilities. This may lead participants to fear participating in the study or being open and honest with healthcare professionals. Participants may also fear their confidentiality because of this distrust. To combat these barriers, I will ensure that participants have a full understanding of the study purpose, design, and procedures. Informed consent will be completed online via email or via paper at a clinic appointment if preferred by the participant. A formal informed consent form was created that explains the purpose, background, participation requirements, and privacy. Each participant must complete prior to the start of the study. Participants are made aware that their decision to participate in this study is completely voluntary, and if they decide not to participate in the study, it will not affect the care, services, or benefits to which they are entitled. Withdrawal from the study is appropriate at any time without penalty. And these are my references.